For decades, we've been told that more medical testing means better health, that the key to living longer is catching every potential problem early through routine screenings. But what if I told you that after age 70, some of these essential tests might actually be doing more harm than good? What if the very screenings your doctor insists on could be shortening your life rather than extending it? I'm here today, not as someone trying to scare you away from medical care, but as someone committed to helping you navigate the complex world of senior health with wisdom and discernment. The truth is, the medical establishment has created a one-size-fits-all approach to screening that completely ignores the unique realities of aging bodies. Today, I want to share 4 routine screenings that you should seriously question after 70, and more importantly, why your doctor probably won't tell you about their limitations. The fundamental problem lies in how medical research has traditionally been conducted. Most screening guidelines were developed based on studies of younger, healthier populations. When these same protocols are applied to seniors, especially those over 70, the risk-benefit equation changes dramatically. Your body at 75 is not simply an older version of your body at 50. It's a complex biological system with different priorities, different healing capacities, and different tolerance for medical interventions. Let's start with perhaps the most controversial screening on our list: routine mammography for women over 70. The medical establishment has drilled into us that annual mammograms save lives, and for many women, they absolutely do. But after 70, the science tells a very different story that most doctors simply won't discuss with their patients. The harsh reality is that mammograms in women over 70 often detect cancers that would never have become life-threatening. This phenomenon, called overdiagnosis, occurs because many breast cancers in elderly women grow so slowly that the woman will die of something else entirely before the cancer ever causes problems. Studies show that up to 30% of breast cancers detected in women over 70 fall into this category. Think about what this means for a moment. You undergo the stress of an abnormal mammogram, followed by biopsies, surgery, possibly radiation or chemotherapy, all for a cancer that was never going to harm you. The treatment itself becomes more dangerous than the disease. For a 75-year-old woman with a life expectancy of 12 years, treating a slow-growing tumor that might take 20 years to become problematic makes little biological sense. The screening process itself carries risks that increase with age. Older breast tissue is more fragile, making the compression during mammography more painful and potentially harmful. False positive rates are higher in seniors due to age-related breast changes, leading to unnecessary anxiety and invasive procedures. The radiation exposure from repeated mammograms, while minimal per test, accumulates over decades and can actually increase cancer risk in very elderly women. What doctors won't tell you is that the largest studies on mammography in women over 70 show no survival benefit. None. The Canadian National Breast Screening Study followed women for over 20 years and found that women over 70 who received regular mammograms lived no longer than those who didn't. Yet somehow, this information rarely makes it into the conversation during your annual physical. The second screening to seriously question is routine colonoscopy after 75. Now, I want to be clear that colon cancer is a serious disease, and early detection can absolutely save lives. But the medical community's obsession with colonoscopy for elderly patients has reached almost religious fervor, despite evidence that suggests we're doing more harm than good. The risks of colonoscopy increase significantly with age. The procedure requires bowel preparation that can be dangerous for seniors, potentially causing severe dehydration and electrolyte imbalances. The sedation used during the procedure carries higher risks for elderly patients, including cardiac events and prolonged cognitive impairment. The colonoscopy itself can cause bleeding, perforation, and infection, all of which are more serious and harder to recover from in older adults. But here's what's really troubling. Most colon cancers take 10 to 15 years to develop from precancerous polyps. If you're 78 years old with a normal life expectancy, are you really going to live long enough for a newly formed polyp to become a life-threatening cancer? The math simply doesn't add up for many elderly patients. Studies have shown that colonoscopy screening provides no survival benefit for adults over 75 with average risk for colon cancer. The United States Preventive Services Task Force actually recommends against routine screening after age 75, yet many gastroenterologists continue to push for these procedures. Why? Because it's profitable. It's what they've always done. And admitting that their specialty's signature procedure might be unnecessary for a large population is difficult. What's particularly frustrating is that there are safer alternatives for colon cancer screening in seniors. Stool-based tests can detect cancer just as effectively as colonoscopy for elderly patients without the risks of an invasive procedure. These tests can be done at home, require no preparation, and cost a fraction of what colonoscopy costs. Yet many doctors dismiss these alternatives or fail to even mention them. Our third questionable screening is routine cardiac stress testing in asymptomatic seniors. The logic seems sound. Test the heart to see if it's getting enough blood, catch problems early, prevent heart attacks. But the reality of stress testing in elderly patients reveals a disturbing pattern of overdiagnosis and inappropriate treatment. The fundamental issue is that abnormalities on stress tests become more common with age, even in people with no symptoms. Age-related changes in the heart and blood vessels can create false positive results, leading to unnecessary cardiac catheterizations and interventions. These procedures carry significant risks for seniors, including kidney damage from contrast dye, bleeding complications, and stroke. Multiple large studies have shown that routine stress testing in asymptomatic patients over 70 does not improve outcomes. In fact, it often leads to a cascade of additional testing and procedures that can harm patients. The American College of Cardiology has stated that stress testing should not be performed in asymptomatic patients, regardless of age, yet it continues to be one of the most frequently ordered tests for seniors. The problem is compounded by what cardiologists call cardiac neurosis. Once an abnormality is found, even if it's clinically insignificant, it becomes very difficult for both doctors and patients to ignore it. Suddenly, a 72-year-old who was hiking and gardening without problems is labeled as having coronary disease and subjected to medications and restrictions that actually decrease their quality of life. What's particularly insidious is that the symptoms that prompt stress testing in seniors, fatigue, shortness of breath, chest discomfort, are often caused by completely different issues. Deconditioning, anemia, sleep disorders, medication side effects, and simple aging can all cause these symptoms. But instead of addressing these more common and treatable causes, doctors often jump straight to expensive cardiac testing. The fourth, and perhaps most surprising screening to question, is routine bone density testing, or DEXA scans, in women over 75. Osteoporosis is a real concern for elderly women, and fractures can certainly be devastating. But the way we've approached bone density screening has created a generation of women terrified of their own skeletons. The fundamental flaw in routine DEXA screening is that bone density is just one factor in fracture risk. Muscle strength, balance, cognitive function, medication use, and home safety are often much more important predictors of who will fall and break bones. Yet, we've become obsessed with a single number, the T-score from a DEXA scan, and base treatment decisions almost entirely on this measurement. For women over 75, especially those over 80, the benefits of osteoporosis medications become questionable. These drugs can reduce fracture risk, but they also carry serious side effects that increase with age and duration of use. Jaw necrosis, unusual fractures, and gastrointestinal problems are all more common in elderly patients taking these medications. What's more troubling is that DEXA scans can't distinguish between different types of bone loss. Some bone loss is a normal part of aging and doesn't necessarily indicate increased fracture risk. But once a woman is labeled as having osteoporosis, she's often started on medications she may not need and may not benefit from. The most effective interventions for preventing fractures in elderly women have nothing to do with bone density medications. Weight-bearing exercise, balance training, vitamin D supplementation, fall prevention strategies, and vision correction have all been shown to significantly reduce fracture risk. These interventions are safer, cheaper, and often more effective than the medications prescribed based on DEXA results. Real-world evidence supports a more thoughtful approach to these screenings. Consider Margaret, a 76-year-old woman who came to see me after her routine physical. Her doctor had scheduled her for a mammogram, colonoscopy, stress test, and DEXA scan, all because that's what we do for women your age. Margaret felt overwhelmed and wondered if all this testing was really necessary. We sat down and looked at her individual situation. She had no family history of breast or colon cancer, no cardiac symptoms, and had never had a fracture. She exercised regularly, ate well, and was on no medications. Her life expectancy, while impossible to predict exactly, was probably 15 to 20 years based on her health status. Together, we decided to skip the mammogram and colonoscopy, replacing the latter with a simple stool test. We focused on maintaining her excellent exercise routine and ensuring adequate vitamin D rather than getting a DEXA scan. Instead of a stress test, we concentrated on optimizing her blood pressure and cholesterol through lifestyle measures. 3 years later, she remains healthy, active, and grateful that she didn't subject herself to unnecessary testing and procedures. Compare this to Robert, a 78-year-old man whose story illustrates the potential harm of routine screening. Despite having no symptoms, his doctor ordered a stress test just to be safe. The test showed some abnormalities, leading to a cardiac catheterization that revealed mild blockages in his arteries. Though these blockages were not causing symptoms and might never have caused problems, Robert underwent stent placement. The procedure went smoothly, but the medications prescribed afterward caused bleeding problems that led to 2 hospitalizations. Robert went from being an active, confident man to someone afraid of physical activity and convinced he had serious heart disease. His quality of life decreased dramatically, and ironically, his actual health probably did too. These stories illustrate a crucial point. The decision to screen should be individualized based on your specific situation, not on arbitrary age cutoffs or one-size-fits-all guidelines. Factors like your overall health, life expectancy, values, and preferences should all play a role in these decisions. So, what should you do with this information? First, understand that questioning routine screening doesn't mean avoiding all medical care. It means being an informed consumer of healthcare who asks thoughtful questions about the tests your doctor recommends. When your doctor suggests a screening test, ask about the potential benefits, the possible harms, and what happens if the test finds something abnormal. Ask specifically about the evidence for the test in people your age with your health status. Many doctors are genuinely unaware that screening guidelines often don't apply to their oldest patients. Some are aware, but find it easier to order tests than to have complex conversations about the limitations of screening. Consider your own values and priorities. If you're someone who wants to know about every possible health issue, regardless of whether it can be effectively treated, routine screening might make sense for you. But if you're more concerned about maintaining your current quality of life and avoiding unnecessary medical interventions, you might choose a different path. Think about your overall health status and life expectancy. If you have multiple chronic conditions or significant functional limitations, aggressive screening for additional problems is less likely to be beneficial. Conversely, if you're in excellent health for your age, some screening might still make sense. Remember that you have the right to refuse any medical test or procedure. You don't need to justify this decision to anyone, and a good doctor will respect your choice even if they disagree with it. If your doctor becomes angry or dismissive when you question their recommendations, it might be time to find a new doctor who respects your autonomy and understands the complexities of geriatric medicine. The goal of healthcare in your 70s and beyond shouldn't be to find every possible abnormality or to follow the same protocols used for younger patients. It should be to help you maintain the best possible quality of life for whatever time you have remaining. Sometimes that means more testing and treatment. Sometimes it means less. The key is making sure the approach fits your individual situation. We've been conditioned to believe that more medical care is always better, that catching problems early is always beneficial, and that screening tests are always worth doing. But the science tells us a more nuanced story, especially for older adults. The medical system has been slow to acknowledge this nuance, partly because it's easier to follow protocols than to individualize care, and partly because there are significant financial incentives to continue routine screening regardless of its appropriateness. The most important thing you can do is to become an active participant in your healthcare decisions rather than a passive recipient of routine protocols. Ask questions, seek second opinions if necessary, and don't be afraid to choose a path that differs from standard recommendations if that path better aligns with your values and goals. Your healthcare after 70 should be about enhancing your life, not just extending it. It should focus on maintaining function, preventing disability, and preserving the activities and relationships that give your life meaning. Sometimes routine screening supports these goals, sometimes it doesn't. The wisdom lies in knowing the difference and having the courage to act on that knowledge. Remember, the goal isn't to live forever. It's to live well for whatever time we have. Making informed decisions about medical screening is one of the most important tools you have for achieving that goal. Your health, your body, your choice. Use that power wisely. 7 blood tests. Your doctor orders, but you don't need after 65. Dr. Evelyn Hart explains.